Welcome to today's Zoom session. We're looking today at bowel problems, and I'm joined by Caroline Davey, who's the advanced physiotherapy practitioner dealing with pelvic floor dysfunction from NHS Tayside. And this is Caroline's first Zoom session, so hopefully we wish her luck and hope it goes well. And I'll hand over to Caroline.
Thanks, Ivan, and thank you for inviting me along today to give this talk. So it's really about half an hour. I'm going to go through various things regarding bowels, assessment, treatment, and then give you all my contact details at the end. So this is the outline of the session. I'm going to spend a little bit of time just talking you through normal bowel function, a little bit about what goes wrong when you've got pelvic floor dysfunction, the main symptoms of pelvic floor dysfunction in relation to bowels, which would be incontinence, but also the other end, which would be constipation. A slide on red flags, just sort of warning signs that we need to look out for, some different treatment options, and then a patient safety alert just to draw your attention to that at the end. So these are your learning outcomes, which I'll not go through. I'll just give you a second to have a look at those. Okay, so starting off with a quote by Samuel Johnson, who was an English writer and critic, and I think this is quite an important quote. Much has been written about the pleasures of sexual intercourse. As far as me, give me a solid movement of the bowel.
I think that says more about Samuel Johnson than anything.
Well, I don't know. I think a lot of people would probably relate to that, and it's probably not until something goes wrong that you think how satisfying it is to be able to move your bowels without any real issues. This is another quote, which I think is really very important as well. So the loss of bowel control, also known as fecal incontinence, can be a devastating problem. There can be few things more embarrassing than a bowel accident that other people notice, and few conditions that create so much anxiety. It's really not a life-threatening problem, but it's absolutely a life-changing problem. And I think as much as we can do to help patients with these problems is, the better. So really just a very brief section on the gut and what's normal. So you can see that when we eat something, it passes through our mouth and esophagus and really our stomach relatively quickly. Things slow down a bit in the small intestine, and really the bit that we're most interested in here is the large intestine or the colon. And the food matter at that point can be in your colon or your large intestine anywhere between 12 and 48 hours. A lot of patients might come to us and say, oh, I had such and such to eat and it came right through me. Sort of saying to them, well, that's pretty much impossible. So it's really, when we're looking at the effect of diet on our gut and our bowel, it's really not what you've necessarily eaten that day that has the effect, but what you've eaten the day before, and perhaps even the day before that can have an effect on the bowel. So mass movements in the colon, basically I often describe your large bowel or your colon a bit like the body's tumble dryer. So when the food goes in one end of it, it's probably the consistency of thick soup. And as it moves through the bowel in these sort of mass motions and waves of contraction, it's like a tumble dryer. So the body will naturally absorb water from that stool. So it goes in like soup, and all going well, it should come out like a formed sausage. So that's kind of how things move through. Bowel emptying is triggered by something called the gastrocolic reflex. So something could be sitting quite happily in our rectum, but when we eat or often drink a hot drink in the morning, that stimulates everything to sort of churn through, and it stimulates us to need to go. So the ideal time to have a bowel motion is probably 30 minutes or so after you've eaten or drunk something. In terms of how often we should move our bowel, sort of in Western society, it varies anything between 3 times a day to 3 times a week, and that's kind of classed as normal. In terms of what normal stool consistency is, we always say we aim for the Goldilocks stool, not too hard and not too soft, just right. So for most of us, it's probably somewhere sitting between about a type 3 and a type 4. When we've got the very hard stool, particularly type 1, that's where you tend to have constipation and straining. And then when you're on the other end of the scale, so a 5, 6 or 7, when it's loose and soft, we tend to have more problems with controlling the bowel and incontinence. So ideally we're aiming for somewhere between a 3 and a 4 as a normal stool consistency. So in terms of what happens when things go wrong, the pictures there just show you the red kind of ring is really showing you the pelvic floor muscles and where they're situated in the female pelvis, which is the top model, and the male pelvis, which is the bottom model. There are various things that can happen if we have dysfunction or weakness in our pelvic floor, but what we're focusing on in today's talk is the bowel problems. So really is what I said at the start: fecal incontinence, constipation, and obstructed defecation. And I'll talk through all of these in a wee bit more detail with you. So fecal incontinence is actually a more common problem than we think. It does affect both men and women of all ages. There was a telephone survey done in America, and that showed 1 in 50 had some problem with bowel control, but it's probably more than that because it is a hidden problem, underreported. People don't really want to admit they have a problem, which is understandable. It's more common as we get older, but not caused just by old age. But it is highest in elderly and institutional care. And it's also quite costly to the NHS and social services as well. The causes are numerous, as you can see, but often in women it's caused by childbirth, difficult childbirth, tears in these muscles during delivery, anal surgery that people might be having for various reasons, for example, hemorrhoids. Fecal incontinence can be caused by overflow, so they're constipated and impacted, and it's this sort of overflow that causes the incontinence. So actually we need to treat the constipation to treat the incontinence. Nerve injury or neurological disease, so things like multiple sclerosis or stroke, can also cause fecal incontinence in our patients. Anal sphincters, so really it's just important to mention that in the anal canal there's actually 2 muscles, and they have very different structures and function. So the internal sphincter is actually a smooth muscle, so it's not a muscle that we can voluntarily control, it's controlled by the brain, and essentially that keeps our anal sphincter or our anus closed at all times, other than hopefully when we're sitting on the toilet. It's a bit like the seal on our bowel, I kind of describe it as. So if you think of a Tupperware dish, that's the seal on your bowel. The external sphincter is the muscle that we can squeeze. So you imagine you're standing in the queue at the supermarket and you had beans for your tea the night before, and you've got a bit of wind and you're thinking, I'm desperately trying to hold this in till I get back to the car. So that's the muscle that you would be squeezing, your external sphincter. So it's a voluntary squeeze. So that's our 2 muscles, and we need both of them to work. So sampling. The bowel's an amazing thing. There's all these things that go on and we don't even realise it. So essentially what happens with sampling is, if you've ever thought about how you know what's in the rectum, so generally we can tell whether it's solid, liquid or gas, and that would then allow us to make the decision on what's appropriate or inappropriate to do in that situation. And what happens is that internal sphincter will relax in the presence of something in the rectum. Whatever's in there descends slightly, and these sensors can tell our brain generally what's there. And that's a really important mechanism. And if we lose that, it really can be quite difficult to manage, because essentially anytime you want to pass wind, for example, you don't know if it's wind or something else, so you have to go and sit on a toilet to pass that. So that's our sampling mechanism. Resisting the urge is also really, really important. And that's essentially if we know we need to go to the toilet, but we're not at the toilet's engaged, we're at work, you're in the car, or you just take your time. If you've got a mobility problem, take your time to get to the toilet. So in the presence again of something there, that external sphincter, that voluntary muscle, should kick in and squeeze and push something back to allow us the time to go there. So it's important that we have that ability to resist the urge, but we don't want people doing it if they're constipated, because actually if you repeatedly do that over a period of time, it will stop giving you the urge to go, and that can lead to constipation. So if you've generally got a problem emptying your bowel, when you've got the urge, don't hang about, get there and go to the loo. So types of fecal incontinence, really we've got 2 main types of fecal incontinence, and you've got urge incontinence or passive incontinence. urge does what it says on the tin. You know you need to go, but you just can't wait to get there. You've got extreme urgency and you actually feel that bowel motion coming down, and in worst case scenario, you lose control of the full bowel. You just can't hold it in. Obviously, you get anxiety and panic if that's happened to you once before. There's always that fear it's going to happen again, and that doesn't help the situation. So that would be our urge incontinence, and that's generally down to that weak external muscle, which remember is the voluntary muscle. So we can do something about it. We can strengthen that and hopefully reduce your urgency. Passive incontinence is an incontinence that you don't know it's happened. And it's that internal sphincter, so that involuntary muscle that's weakened. So your seal is not great. The seal on your Tupperware dish isn't great. So you imagine you put something dry in your Tupperware dish. It's rolling around your rucksack when you're at work. It stays in there. It's fine. But you put something a bit more liquid in there and you roll it around a little bit and it starts to seep through. So that's what you have. People generally don't know they've had the accident until they find it. That can be helped if we get the stool consistency right. So if you have a weak internal sphincter and a loose stool, you're far more likely to have an accident than if you've got a formed Goldilocks stool. So a lot of that's about modifying your stool consistency.
Oh yeah, I didn't really see that there were two types there, the urge and the passive. And I think the passive is something that we see a lot of and probably don't see as a huge thing.
Yeah.
We just deal with it. But
yeah. And there are some things you can do, and it's that kind of, you go back to the toilet and you have to re-wipe after, or you go back and there's a little bit of soiling and it might be on yourself or it might be onto the underwear or the pad.
Yeah.
It doesn't need to be a massive big amount, but it can cause a lot of irritation and itchiness and just general discomfort, and it's not nice to have if we can do something about it. So constipation, before we get on to treatment, the constipation and obstructive defecation, the best way to describe it, if we think to that large bowel image, is the constipation is a getting it around problem. Your tumble dryer's on too long, it's too slow, too much water is getting absorbed out of your stool and it becomes too hard and difficult to pass. A getting it out problem is probably slightly less common, but it's getting around there normally. So you've got a normal stool consistency. You know it's in the rectum, but you just can't pass it. Generally, things that could cause the getting it out problem could be something like a prolapse, a rectocele, it gets stuck in a prolapse, or the muscles of the bowel just not working as they should. The constipation, there's lots of reasons for constipation, particularly in institutional care, lack of mobility, poor fluid intake, lack of dietary fibre. So there's lots of things that we can try and do with that, and also medication. Medication twofold, you can be on lots of constipating medication, so it's trying to see can that be reduced or stopped if possible, and if not, it's adding in the right kind of laxative at the right regime to work best for the individual. So red flags, I'll not go through these because you can refer back to the presentation if you need to, but for ourselves, for our family members, for our clients, it's really important that you are aware of red flags and really any change in bowel habit, because that might need some investigation or discussion with the GP. Just again, probably more for ourselves rather than our clients, but it's really important to engage in the bowel screening, which in Scotland is from the age of 50 to 74. Every 2 years you'll get a lovely kit through the door, and you need to send it off and do it because it's really important to take part in that.
Is there good engagement with that, or is that a message that you really want to push to everyone? I'm
always pushing to everybody, because actually bowel cancer is one of those cancers that if caught early it can be really, really well treated, and the uptake has improved because in the last probably 2 years they've changed it. You used to have to do 3 samples, it's now 1. So a lot of people, particularly if you're constipated, it's really hard to get those 3 samples in, so it's no excuses, it's now 1 sample, off you go, and that's you for 2 years. So I always encourage people whenever I've got an audience to say, do it. Okay, so on to what I would say is slightly more interesting stuff for the second half of the presentation. So it's really sort of the things that, what can we do to basically help our patients? So in terms of diet, really what we're looking there is fibre. There's two types of fibre. There's insoluble and soluble. This is just whether it can be dissolved in water, but basically we don't absorb or digest fibre. In a way, it passes through our gut, but it's really important for a healthy gut. So it's just trying to make sure that we have, fruit, veg, whole grains, oats, legumes, so lentils, all these kind of wide variety in our diet. But also you really need a good fluid intake, because it's all very well having all this fibre, but if you're not drinking enough, it's not going to go anywhere. So too much fibre can actually constipate you as well. So it's getting the balance right, but also making sure we've got good intake of fluid with our clients to kind of help move things along. Also in there is things like caffeine. So particularly if we have problems with loose stool or urgency or incontinence, caffeine is going to make that worse because it stimulates our gut. So in those type of individuals, it's maybe switching over onto decaffeinated tea and coffee. And the taste is absolutely fine. I would struggle to tell the difference between them, but it can make a big improvement with bladder and bowel problems. So it's maybe just trying to wean somebody off the caffeine and onto decaf. Other things that can affect your gut, so things like high fat foods, gravies, really rich foods can also make us quite loose as well. So it's kind of looking at what particular problem that patient has, and can we make slight alterations into their diet. I do have sheets on what can affect your stool consistency, so if anybody wants to contact me, I can send you information leaflets on that as well. Medication, pelvic floor and holding on, I'm going to talk to you in a further slide. Other things just to mention here would be containment. So there are products and pads available, as you probably know, that can contain. You're not going to get any absorption with a pad of fecal matter, but you can contain it. There are anal inserts which are not appropriate for everybody, but there are small devices that can be put into the back passage if you've got that soiling, that passive soiling I talked about, which can be useful. And then always thinking about onward referral if that's appropriate to our colleagues in secondary care, so colorectal colleagues, if there are issues and you need any further investigation or treatment. So really just quickly showing you about pelvic floor muscles. Everybody's got a pelvic floor, man, woman and child, and everybody can work their pelvic floor. We've heard it all. Don't have one of those, or not working since I've had the children. We can all improve on our pelvic floor. So basically we want to do our pelvic floor exercises regularly, i.e. daily, to strengthen these muscles. They have to be practiced for 15 to 20 weeks to see a difference, so it's not going to work tomorrow. And you need to keep doing it. If you don't use it, you lose it. So we always have to think about our pelvic floor. And essentially the best way to describe how to squeeze, this is the way I would describe it to my patients, is what you want to think about is drawing in and lifting at the back passage as if you're holding in wind, and the same at the front, drawing and lifting in as if you're doing a midstream stop. Most of us ladies know what that is. Basically, you're passing urine and you're trying to stop that flow. So it's that action of squeezing and lifting at the back, squeezing and lifting at the front, holding it and then letting it go. You don't need to lie down to do it. You don't need to get into a lycra spandex suit to do it. Nobody knows you're doing it. You can sit, watch the telly and do it. If your buttocks are clenching and you're bouncing up and down on the seat, or your eyebrows are going up and down, you're probably not doing it right, and you might want to think again or contact ourselves or somebody just to get a bit more in-depth instruction on how to do
There's
pelvic
probably
floor.
a YouTube video somewhere.
Oh, there'll be hundreds of YouTube stuff about pelvic floor.
You should be able to Google them if you're struggling.
Definitely, absolutely, but really, really important, particularly for that external sphincter to help with the urgency side of things as well. Another thing that we can do for urgency is the holding on program. We like things that kind of do what they say on the tin. You could probably work out what I'm going to say by just calling it the holding on program. But essentially what you're trying to do is increase your holding on or your deferment time. So what you need to do if you've got urgency and urgent incontinence is you know you need to go, you get to the safe place, you get to the toilet, the bathroom, and you hold it in for a minute, and then you go, and then you progressively try and increase the time that you're able to hold on. And it can work really well. You're contracting your muscle at the same time. It is quite difficult if you're undressed and sitting on the loo doing it. So I usually say maybe put the lid down and sit on the lid of the loo seat, or even sit on the edge of the bath and hold on. But that can work quite well. One of my favourite things is a thing called defecation dynamics, which is essentially telling you how to sit on the toilet. We were designed to squat. We weren't designed to sit on these lovely high toilets, particularly worse if you've got a raised toilet seat, which I know lots of people have. It is not good to empty your bowel on a raised toilet seat. So it's trying to work out what you can do for an individual. But to get us in a squatting position, we don't need to go out in the garden and dig a hole. We can just raise our feet up. So you get things called squatty potty, which is what you can see in the picture there, which is essentially a bit of plastic that you pay £30 for, but you could go out and get footstools from the pound shop or wherever, and get the same idea. So you're trying to raise the knees above the hips, if that's possible, in a relaxed position, so it unkinks, for want of a better expression, unkinks the bowel and just makes it far easier to pass your bowel motion, because you're not going round this corner. It's a much more vertical passage out, and that can make a huge difference to patients just by changing their position on the toilet. So if you don't need a raised toilet seat, get rid of it, and if possible, get the feet raised up on a footstool.
Okay, so you would recommend that we sort of get those stools and make use of that position?
Definitely, and it's just reminding people to kind of, it's having it there, so you don't have to then, where's that footstool? I don't have time to go and get it. It's having it there handy, that they can be wiped down. They're handy to have. Just bring it round when you're on the toilet, and then they can be kicked to the side. The good thing about these squatty potties is they've got a cutout, so you can actually push it back, so when it's not in use, it's not in the way, because what you don't want is a trip hazard either. No. So they're quite good, but you can Google squatty potty and get lots of fun videos about rainbow unicorns pouring ice cream, which is another YouTube video. Brilliant. If you're that way inclined, you can go and have a look at that, and that's done by squatty potty. If you want to know more,
yes,
Google squatty potty.
I'm sure. Yes,
I'll leave that for
no, that's fine. That's fine.
So that's a useful thing to do. Medication, sometimes underused. If somebody has a very loose stool, then Fibogel can be quite useful as a bulking agent, so it bulks people up. It's quite good also if you fluctuate from constipation to loose, because it kind of keeps you in the middle. So people take it for constipation, people also take it for loose stool. You have to be careful with the frail elderly with that, because it just bulks you up and it can cause constipation if you don't have an adequate fluid intake, and it's not suitable for opioid-induced constipation, but otherwise it can be quite useful to try for these bowel problems. If it's purely loose stool and diarrhea that's the problem, obviously assuming it's not anything that warrants any further investigation, so it was a chronic problem, using loperamide or Imodium is actually really, really useful. Often I would start it in the liquid form, because I think even people with fecal incontinence, their big fear is that they're going to be constipated. So if you start it in a liquid form on prescription, you can titrate it up to try and get their stools, that Goldilocks stool, which is just right. And then obviously laxatives if it's constipation. Laxidol probably is more preferable to lactulose. Lactulose gives you an awful lot of wind, which is what patients tend to complain, not so much with Laxidol. So it's just being aware that medication can be used for these patients. I put this slide in because it's a bit more fun. It's really just some of our bells and whistles, we call it. So some devices that we might use within the physiotherapy department to improve pelvic floor function. So we've got various forms of biofeedback that you can be linked up to a computer. There's weights that can go inside the vagina to help improve your pelvic floor. And probably for the staff as well, the one on the top left is this app called Squeezy NHS. Brilliant app to remind you to do pelvic floor exercises. There's a male and female version, so nobody misses out. Lots of information there. You can set reminders to do pelvic floor. So it's definitely worth having a look at that for your own use as well. So
that's the one in the top left as we're looking.
Yes.
Squeezy
NHS, and it's on Android and Apple. You can download it. It's fab. Technology is always changing. The LV, which is the one on the top right as you're looking at the screen, this is a Bluetooth device. So it links this device that you put inside the vagina with your mobile phone and tells you how well you're doing. I haven't really seen one of those in action, but that's the way things are going. It's always changing. So watch this space if you want to know more. So this was something that I was asked to put into this just to draw your attention to. It's not really something I would know much about, but it is related to the bowels. There is a patient safety alert for patients at risk of autonomic dysreflexia. So basically, patients with spinal cord injury or neurological conditions may have neurogenic bowel dysfunction, which means that they depend on routine interventional bowel care, including digital manual removal of feces. So basically, some of these patients can be susceptible to a potentially life-threatening condition, which is basically a rapid rise in blood pressure, risking hemorrhage and potentially death. So really, it can be caused by non-adherence to a patient's usual bowel routine during or following interventional bowel care. So there's a link there, so please go and have a look at that if some of your patients might be at risk of that. And there's also an RCN guidance for management of lower bowel dysfunction, which it might be worth having a look at as well, and you can get that online.
I mean, that would be for a small number of people.
Oh, absolutely, but it's just sort of highlighting it to everybody just so they know that, you know, to look at those resources if need be. And I think that probably draws the session to a close.
No, that's really helpful. The bits that I think that we would take from that are the diet, the lifestyle, and a lot of the stuff around your exercises and stuff like that.
Definitely.
And it's not just for the people we look after.
No, for everybody.
We can do a lot of preventative work ourselves.
Yeah.
No matter what age we are, we should be thinking about, especially pelvic floor.
Definitely.
And bowel screening for the over 50s.
Bowel screening, yeah, and just don't put up with these things. You know, if you've got a problem and you're struggling with it, go and see the GP, because there are people out there that can help. And for your clients, definitely it's bowel routine. It's just looking at the wider picture and just making small changes that can make a big difference.
And those are contact numbers there. You did say earlier that you had a sheet that you would give out if people wanted it.
Yeah, it's one of our NHS patient information leaflets.
Could you therefore send me a link to that, and I can send it out to people when I let them know about this? Then I
can send you the pelvic floor ones as well.
Excellent. Well, thank you very much. That was really enlightening.